We all know that the primary function of the immune system is host protection. The components of the immune system play in an orchestrated manner in order to provide optimum protection for host survival. Let's have a little review about the components of our immune system. We have a first line of defense that provides an anatomical barrier against invading pathogens. We have our unbroken skin, the mucosal surfaces, the enzymes found in our secretions, example, lysozymes. We also have our cells that act as defense armies, our white blood cells that help fight infections. And we also have proteins that provide protection, proteins such as the complement system, the antibodies, all of which help to remove the invading pathogens. However, despite the protection provided by our immune system, pathogenic organisms have their own evading mechanism. They can develop a way that will allow them to resist the protective mechanism of our immune system. And when such happens, they are able to successfully establish infections. Some of these infections are invasive in nature. They will target our internal organs, and the consequent effects may be systemic. It is therefore important that infections from such organisms must be detected as early as possible in order to avoid complications or worst, death. Good day, juniors. For today's lecture, we're going to discuss one serologic method that will allow clinicians to detect a certain bacterial infection. At the end of our discussion, it is expected that you guys will be able to discuss the characteristics of the etiologic agent of streptococcal infection, trace the mechanism of immunopathogenicity of streptococcal agent, describe the antistreptolysin O and its activity, discuss the clinical applications of antistreptolysin O, virtually perform antistreptolysin O qualitative tests, and accurately interpret and report ASO results. Streptococcal infections. Primarily, the causative agent is the genus Streptococcus. They are called Streptococcus because strep, the bacterial cells, are arranged in chains, and coccus because the bacterial cells are spherical in shape. Under the microscope, they appear purple. Hence, they are categorized as gram-positive. The genus Streptococcus is divided into different groups according to the components of their cell wall. They have fimbriae that will allow them to adhere to the human epithelial lining. Example, epithelium in our respiratory tract, where they can establish an infection. The Streptococcus genus is actually considered a normal flora of the upper respiratory tract, and children are considered carriers. Being residents of the upper respiratory tract, they can be transmitted via respiratory droplets, and there is easy transmission in crowded places. Now, one member of this genus belongs to Group A according to the Lancefield classification, representing Streptococcus pyogenes. Streptococcus pyogenes class is actually ubiquitous, meaning you can find this organism anywhere. And as I have mentioned, they are considered normal flora of the respiratory tract of some people. However, class, given the opportunity, Streptococcus pyogenes can be pathogenic. And as a pathogen, Streptococcus pyogenes uses its virulence factors in order to establish infection and cause disease. These virulence factors are, example, the M protein found in the fimbriae of the organism. The M protein, the fimbriae, will allow the organism to adhere to the epithelial lining, example, in our respiratory tract or in our skin. The organism also has a capsule. The capsule will help to evade the phagocytic activity of our white blood cells. Streptococcus pyogenes can also release toxins, SPEA, B, and C. No, and these toxins are released as the organism establishes the infection. And it can also produce enzymes such as streptokinase, protease, DNase, hyaluronidase, NADase. These enzymes will allow the organism to have deep tissue invasion. And your Streptococcus pyogenes class, typically it produces streptolysins. Streptolysins are actually hemolytic exotoxins. Hemolytic meaning they can cause destruction of our RBCs. And there are two types of streptolysins. We have the streptolysin O, which is oxygen labile, and streptolysin S, which is oxygen stable. Now, for you to not interchange the two, tandaan niyo lang yung letter S. S for stable. Again, streptolysin S, oxygen stable. Streptolysin O, oxygen labile. Now, all of these virulence factors of Streptococcus pyogenes class are antigenic in nature. When we say antigenic, they are able to bind to the antibodies which the antigens are directed to. Example, itong streptolysin O. The antigen streptolysin O will bind to its corresponding antibody, which is anti-streptolysin O. So, streptolysin O antigen will bind with anti-streptolysin O antibody. DNAs, for example, these DNAs will bind with anti-DNase antibodies. So, ganon ang ating streptococcal antigens. Yung antigens, in the presence of the corresponding antibody, magbabind yan sila together. Now, some of these antigens class are immunogenic in nature. Immunogenic meaning they are capable of inducing an immune response. Immune response such as activation of the lymphocytes and antibody production. Now, as I have mentioned earlier, that there are streptococcal antigens that are immunogenic in nature. Example, streptolysin O. Streptolysin O can cause activation of B lymphocytes. When B lymphocyte is activated, it is converted into plasma cells. And these plasma cells will produce antibodies directed against streptolysin O. And these are called the anti-streptolysin O antibodies. Now, the antibodies typically produced during streptococcal infections are anti-hyaluronidase, anti-streptokinase, anti-DNase, anti-NADase, anti-streptolysin S, and anti-streptolysin O. Group A Streptococcus class can cause a variety of infections. It can cause skin infections such as impetigo and necrotizing fasciitis. Necrotizing fasciitis meaning there is inflammation in the fascia. And the inflammation in the fascia causes tissue death. Kaya nagkakaroon ng necrosis. Now, in this type of infection class, the Streptococcus pyogenes is referred to as flesh-eating bacteria because it is like your tissues are being eaten up by the organism. It starts merely with a mild infection that when becomes untreated, the infected tissue becomes necrotic. Nagkakaroon ng necrosis. Now, aside from necrotizing fasciitis, streptococcal skin infection may also manifest as impetigo. Now, impetigo is common in children sa kanilang mouth, hands, and in their feet. Now, when this severe skin or soft tissue infection class becomes untreated, it may progress to streptococcal toxic shock syndrome. And toxic shock syndrome is a life-threatening disease. And it will also affect multiple organs. So in here, the patient, during streptococcal toxic shock syndrome, the patient experiences cytokine storm and a shock, no? And then this will consequently result to renal failure. And if the shock is not addressed, no, the patient may die. And of course, we are also familiar with strep throat. This is actually pharyngitis, no, class, presenting with a redness and inflammation of our throat, no? In children naman, class, meron tayong tinatawag na scarlet fever. Scarlet kasi there is the appearance of a bright red rash all over the body, no? And then the bright red rash is accompanied by soreness of the tongue. There is also soreness of the throat and a high fever. So, scarlet fever, pwede siya mag-manifest as a skin infection and also a respiratory tract infection. Now, all of the diseases I have mentioned are treatable with appropriate antibiotics. Therefore, it is important for a timely diagnosis and treatment. Now, example, sore throat. Siyempre, di naman talaga all the time na pag may nararamdaman tayo, di ba, diretso tayo sa doctor. Hindi yun ganun. Lalo na ngayon, may COVID. No? Sometimes we do home remedies muna, like gargle with oral antiseptics, Actidol muna, or take paracetamol for fever. But if you have noticed, class, that the signs and symptoms have progressed, mas lalong lumayla yung sore throat mo, yung fever mo on and off, pang ilang araw na hindi talaga nawawala, no? When that happens, you better have yourselves checked, no? Because class, remember that fever is a sign that something is wrong going on inside your body. It may be acute and benign, does not need any treatment, or it may need a treatment. The earlier the diagnosis, the earlier the treatment. Hence, the lesser risk for complications. However, some people don't have any symptoms during a streptococcal infection, no? And they may not know that they already need a treatment. When this happens, untreated streptococcal infection can lead to future complications. And these complications are termed as post-streptococcal sequelae. These complications may affect the kidneys, causing acute glomerulonephritis, or it may affect the heart, causing rheumatic fever or even rheumatic heart disease. Now, these complications just usually start with a simple streptococcal infection that is untreated, no? So, let's start with the first streptococcal sequela, rheumatic fever or rheumatic heart disease. Now, what happens in rheumatic fever? Rheumatic fever actually affects not just the heart, it also affects the brain, the joints, kaya rheumatic kasi there is joint pain, and it also affects the skin. So, rheumatic fever starts with a Streptococcus pyogenes infection. As we have mentioned kanina, there are streptococcal antigens that are immunogenic, meaning these antigens can cause antibody production. So the streptococcal antibodies produced, no, they are found in our blood, no, they will enter our bloodstream. They will travel to the different organs of our body through our blood, and they may potentially be deposited in our heart tissues. In our heart tissues, in our heart muscles, they may exhibit cross-reactivity. Cross-reactivity between antigens occurs when an antibody directed against one specific antigen is successful in binding with another different antigen. In other words, class, the antibodies produced are supposed to be directed against streptococcal antigens only. But because these antibodies exhibit cross-reactivity, they are also able to bind with our myocardial tissues. These antibodies become deposited in the myocardial tissues, and they can trigger an immune reaction which will attack the myocardium, and this will cause a significant damage in our heart tissues. No? And it's not only the heart tissues that may be affected. The heart valves may also become involved that will lead to rheumatic heart disease. Again, let me repeat. During streptococcal infection, there are there is streptococcal antibody production. The antibody produced are supposed to be directed against streptococcal antigens only. But these streptococcal antibodies, when they are found in our blood, they have access in our blood, they can travel to the different organs in our body, and they can land in our heart tissues. In our heart tissues, they can bind there. Bakit sila makabind sa ating heart tissues? Because these antibodies exhibit cross-reactivity with our heart tissues. So, hindi lang sila nagre-react or nagbabind against streptococcal antigens, they can also bind with our myocardial tissues. And when they become deposited in our myocardial tissues, they can trigger an immune response. And the immune reaction can cause a damage in our myocardial tissues and also in our heart valves, which may result into rheumatic heart disease. I hope that's clear. Now, this sequela of post-strep infection is common among children. I don't know if you have heard some adults say na it's not good kapag pabalik-balik ang sore throat kasi it can also affect the heart. 'Di ba? Narinig niyo na ba yan? Actually, it's true na when you have a repeated sore throat, it can also affect our heart. However, sabi ng ibang adults, yung bacteria daw coming from the throat will go down to the heart. But it's not actually like that, no? It is actually due to streptococcal antibodies cross-reacting with the myocardial tissue. Okay, I hope that's clear. Another sequela is acute glomerulonephritis. This affects our kidneys, particularly the glomerulus. So what happens here? This is actually immune complex mediated. Di ba sabi natin kanina, streptococcal antigens will bind to their corresponding streptococcal antibodies. And the binding is called an immune complex. Now, these immune complex, when they gain access in our blood, no, they can travel to the different organs of our body. And they may become deposited in our kidneys. So the immune complex becomes deposited in our kidneys, particularly in the glomerulus. Now, the presence of the immune complex in the glomerulus can cause activation of an immune response. Bakit na-activate ang ating immune system? Kasi our immune system have to remove the immune complex deposited in the glomerulus. So, pwedeng ma-activate ang number 1, ang ating complement proteins. Pag ma-activate ang ating complement class, it can cause cell lysis. Now, remember, the immune complex are deposited in the glomerular cells. And when the complement is activated, the glomerular cells may cause damage. Pwedeng magkaroon ng lysis of the glomerular cells. Bakit na involve ang ating glomerular cells? Kasi nga, class, yung immune complex na deposit sa ating glomerulus. So, nagkakaroon ng collateral damage. Okay? Now, another mechanism or another immune response that will be activated are our phagocytic cells. When our phagocytic cells are activated, again, bakit kailangan ma-activate ng ating phagocytic cells? Because these phagocytic cells have to remove the immune complexes deposited in the glomerular tissue. So again, during the process of removing these immune complex, nagkakaroon ng collateral damage sa ating glomerulus. Hindi talaga yung glomerulus natin ang target, but rather the immune complex. Nadamay lang ang ating glomerulus kasi it is in the glomerulus that these immune complexes are deposited. No? So when the glomerulus is damaged, of course, it can affect the function of our kidneys. Magkakaroon ng damage in the filtering capacity of our kidneys. So pwedeng excrete ng proteins in our urine. There will be proteinuria or there will be presence of blood in our urine. Nagkakaroon ng hematuria. No? Ganon. Now, this condition naman, class, is manageable. And actually, the patient can recover without further complications after a few weeks of treatment or management. But there is always the risk of progression to a long-term kidney damage. Kaya a timely diagnosis is important in order to administer treatment as early as possible. Now, with that being said, again, this calls for a timely diagnosis and treatment. So we have a sample case here. Our patient is Maria Clara, 29 years old female. She comes for a checkup because of a lower back pain, a bloody urine, and edema on her lower extremities. Hearing such, the doctor suspects of acute glomerulonephritis. But class, remember, there are different causes of glomerular nephritis, not just streptococcal infection. So the doctor asked, Maria Clara, did you have a recent streptococcal infection? Nagka-sore throat ka ba? Maria Clara denies and said na wala naman siyang sore throat except for a fever 3 weeks ago. Now, question. Should the doctor end there? Should he rule out past streptococcal infection just because sinabi ni Maria Clara na wala siya nagka-sore throat? Of course, the doctor can't be sure about that. So it is imperative to determine a recent strep infection. Plus, remember that streptococcal infection can be asymptomatic in some people. So the doctor can't be sure if Maria is or had a previous streptococcal infection. So the doctor had to rule that out, no? Now, streptococcal infection can be detected by the following methods. Of course, bacterial culture is a very good diagnostic tool because through bacterial culture, we will be able to isolate and identify the causative agent, which is the Streptococcus pyogenes. Therefore, definitive siya and less prone to error when properly done. We can also detect for the presence of streptococcal antigen. But remember, these testing methods are appropriate during an active infection when the organism is still present in the patient's body or when the streptococcal antigens are not yet cleared out from the body. But again, as I have mentioned earlier, there are streptococcal infections that manifest asymptomatically in some people. So, some patients won't really bother going to the doctor for a checkup. Pupunta lang yan sila pag may iba na silang nararamdaman, like sa case ni Maria Clara. So, anong best na gagawin ng doctor? Sa case ni Maria Clara, kasi sabi ni Maria Clara, wala naman daw siyang nagka-sore throat. Wala naman siyang nararamdaman at the moment na pumunta siya sa doctor for a checkup. No? So, what can the doctor do? Yes, the doctor can order for a test that will detect streptococcal antibodies. Now, why should the doctor request for detection of antibodies? Bakit antibodies? Yes, exactly. Kasi class, there is no longer active infection. The causative agent may no longer be present. No? Tapos na kasi ang infection eh. So, wala na ang organism, wala na ang bacteria. So, wala na tayong ma-isolate na bacteria. And probably, wala na ring antigen kasi na-clear off na ng ating body. But, we can surely detect the presence of streptococcal antibodies. So we can detect anti-streptolysin O, anti-DNase, anti-hyaluronidase, etc. No, we can detect those antibodies. Now, there are different methods in detecting streptococcal antibodies. And the most common method of detection is through agglutination reaction. Now, this GIF here actually demonstrates the principle of agglutination. Agglutination occurs when you have antigen, is circles here, and your antibodies, itong Y, no? The antigen in the presence of the antibody, corresponding antibody, will bind and will cause cross-linking. Now, this cross-linking is visibly seen as agglutination or clumping. So, agglutination is defined as the process by which particulate antigens, such as cells, aggregate to form large complex when a specific antibody is present. Now, when it comes to detection of streptococcal antibodies class, anti-streptolysin O and anti-DNase are actually the most common. But before we proceed with the discussion of ASO, allow me to briefly discuss agglutination. You will actually have a more detailed discussion about agglutination in your lecture sa finals, no? So, for now, i-run through lang natin overview what is agglutination, the principle of agglutination. So as I have mentioned earlier, class, antigens in the presence of the corresponding antibodies will bind together. Now, this binding, the cross-linked binding, is visibly seen as agglutination or clumping. There are actually different types of agglutination. But in this lecture, I will only mention two, direct agglutination and indirect agglutination. Direct agglutination follows the basic principle of agglutination that when an antigen is present in the and corresponding antibody is present, they will bind together, causing a cross-link binding, and this cross-link binding is visibly seen as agglutination or clumping. Now, it is called direct agglutination because the antigens are innately or naturally found on a particle. In the presence of specific antibodies, the antigens which are naturally found on the surface of the particle will bind with the antibodies to which these antigens are specific for, causing a clumping of the particle. Again, the antigens here are naturally found on the surface of the particle. Typical example here is your ABO, blood typing. In ABO blood typing, the antigens are the A, B, and AB antigens. These antigens are naturally found on the surface of our red blood cells. So, kung blood type A ka, you have the A antigen on your RBC. Kung type B, you have the B antigen. AB, if you have both antigens, and type O, if you don't have the antigen. So, we will identify the antigen present on the surface of the RBC using anti-serum as reagent. Antigen, antibody, no? So, the antigen here will bind with the corresponding antibody. The binding will cause a cross-linking and visibly seen as agglutination, as in this case. So, in this part here, there is no agglutination. As you can see, homogeneous ang mixture. Whereas in this reaction, there is a visible agglutination. No? So this one here, absence of agglutination, therefore absence of the antigen. Presence of agglutination, therefore presence of antigen. Another example class is bacterial agglutination. So here, the antigens are naturally found on the surface of the bacteria. Kaya categorized siya as direct agglutination. Again, direct because the antigen is naturally found on the surface of the particle. The particle may be an RBC or pwede ring bacteria. Now, in contrast to direct agglutination is the indirect agglutination. Indirect agglutination is also known as passive agglutination. What differentiates indirect agglutination from direct agglutination is the fact that the antigens here are not naturally found on the surface of the particle. The antigens here are intentionally incorporated to carrier molecules. The specific antibodies will bind to the antigens that they are directed to. Again, I want to emphasize that in the indirect agglutination, the antigens are intentionally incorporated to a carrier molecule. In other words, the antigens here have carrier particles. In this image here, class, the carrier is the RBC. The RBCs here are coated with the antigen of interest. No? So this differs from direct agglutination in the sense that these antigens, etong blue dito, are intentionally and synthetically attached to the surface of the RBC. Example, viral antigen, influenza antigen for example. Normally, wala naman talagang influenza antigen sa surface ng ating RBC. But we can attach these antigens on the surface of the RBCs, however, synthetically. Sasadyain talaga nating ikabit sa surface ng RBC ang influenza antigen. So in this manner, the RBC becomes the carrier of the influenza antigen. And in the presence of the corresponding antibody, no, against the influenza antigen, there will be an antigen-antibody binding, and cross-link binding can cause agglutination. And this is because the influenza antigen, no, found on the surface of the RBC will cause agglutination of the RBC. Siyempre, kasali si RBC na mag-a-agglutinate kasi siya yung carrier ng antigen. So, because of that, we are able to visualize the agglutination reaction. Now, there are actually different carriers in indirect agglutination. We can use RBCs as carrier. Now, class, any type of agglutination, if involved ang RBCs, we call it as heme agglutination. So, the heme there indicates that the antigen is found on the RBC. Direct heme agglutination, kapag the antigen is naturally found on the surface of the RBC. Indirect heme agglutination if the antigen is synthetically found on the surface of the RBC. So ganito yung nangyayari, the carrier particle, and you have the antigen of interest. The antigen of interest is allowed to coat the carrier particle. So with that, the carrier particle plus the antigen in the presence of the antibody will cause antigen-antibody binding. Cross-linking will cause or is visibly seen as a visible agglutination. Aside from RBCs, we can also use latex, charcoal, gelatin, silicates, and beads as the carriers. Now, why did I mention direct and indirect agglutination? Class, because ASO testing employs, yes, indirect agglutination. It is indirect agglutination because the antigen, which is the streptolysin O, is artificially incorporated to the carrier molecule, which is the latex particles. So, ganito yung appearance niya, class. It basically looks like this. The latex particle is coated with the streptolysin O antigen. So the latex here will help us visualize the reaction, which is a visible agglutination. So, Going back to our case of Maria Clara. The doctor wants to know if she had a recent streptococcal infection. So the doctor ordered ASO testing. So here, technically, in ASO testing, we are trying to detect the presence of ASO antibodies present in the patient sample. And antibodies can be found in our blood, particularly in the liquid portion of our blood. So the recommended specimen here is serum. Okay, question. Serum. Ma'am, can we use plasma instead of serum? Yes, class. You may use plasma naman, but serum is recommended kasi less problematic ang testing with serum than with plasma. There are cases kasi that the antibody level is lower in plasma than in serum. This is probably because of the interference caused by the use of anticoagulants. And likewise, class, limited lang din kasi ang anticoagulant na compatible with serologic testing. Pinaka-compatible is heparin, green top. But heparinized tubes are pricey. So, di siya cost-effective for the laboratory. Lalo pa kung limited ang budget ng laboratory. So, it is always safe to use serum kasi pwede lang naman plain red top tube ang gagamitin natin. But you can also use gel separator tubes class ha, so long as serum ang liquid portion ng ating ma-isolate or ma-extract from the blood sample. Now, class, during testing, syempre dapat we process the samples right away. But if delay is anticipated, it is important to properly store your samples to avoid degradation of the antibodies. Now, if delay is less than 24 hours, you can simply place the serum sample in the refrigerator. Again, class ha, serum sample lamang. Dapat na-separate mo ang serum. Hindi mo pwedeng i-refrigerate yung buong tube. Kasi pag i-refrigerate mo yung buong tube, pwedeng magkakos ng lysis ng RBC. Tapos pag hemolyze yung sample natin, hindi na natin pwedeng magamit. So you have to separate the serum sample. And then serum lang yung ilalagay mo sa refrigerator if the delay is anticipated in less than 24 hours. But if the delay is more than 24 hours, it is appropriate that you place the serum sample in the freezer at negative 20 degrees Celsius. Now, frozen samples must be thawed first at 37 degrees Celsius before using. So, kailangan nyo muna ipatunaw at 37 degrees Celsius. Contraindicated samples. Contraindications, never ever use these samples that are lipemic, hemolyzed, or with bacterial contamination. Because class, these contraindicated samples may cause false positive or false negative reactions. Lipemic samples, these are samples that appear milky. Class serum kasi is expected to have a clear appearance like in this picture here. But if mapansin mo milky siya, turbid siya, whitish siya, probably that is lipemic. So, hindi mo pwedeng i-process yung sample kung lipemic. Hemolyzed samples, basically reddish ang color ng serum. And the reddish color is because of the release of the hemoglobin. So, when you receive a hemolyzed sample again, hindi siya pwedeng i-process. Always repeat collection. So, how do we perform ASO testing? So, first, start with sample preparation. Again, the recommended sample to use is a serum sample. So, separate the serum sample. After which, you get your reagent. Class, before any testing, always check the box for expiry date and for any signs of contamination. Pag nakita mo na expired na yung reagent, syempre papalitan mo, kukuha ka ng bagong box ng reagent. Pag nakita mo contaminated na yung reagents, syempre papalitan mo din, hindi ka pwedeng gumamit ng reagent na merong contamination because contamination can cause either false positive or false negative reactions. After checking the box, perform the procedure, which we're going to detail in a little while, and interpret the reaction, and after which, report the result. So here is a short video of how to perform qualitative ASO latex agglutination. Okay. So these are the expected reactions. Class, by the way, procedure for the latex agglutination testing are actually the same, almost the same for all or for other latex agglutination tests. But you have to check the package insert for specific procedure kasi nagdi-different sila minsan sa amount ng sample na ilalagay sa testing or gagamitin during testing. So always check for the package insert for the procedure. But basically, yung procedure is how it was shown in the video. So these are the expected reactions after ASO latex agglutination tests. So positive when there is agglutination, you see there is a clumping. Negative when no agglutination is seen, the fluid is homogeneous, and no clumping is seen. Now, class, you may also need to grade the positive reaction according to the strength of the agglutination. The grading may depend on the manufacturer of the reagent or according to the standards of your laboratory. Surely merong na-set ang laboratory niyan na, sa manual on how agglutination should be graded, no? Or you can refer to the package insert to be safe. So again, positive when there is a presence of agglutination or clumping, and negative, absence of agglutination or clumping. Now, are we ready to report the results? Nope, not yet. Why? Because class, as part of the diagnostic team, it is expected that the laboratory results we release are accurate and should reflect the true condition of the patient. So in order to eliminate errors contributed by the operator, yes, pwedeng makakos ng error si medtech. or errors caused by the machine or the reagents, no? In order to eliminate those sources of error, we should do a quality control check in all the testing methods that we perform. So, hindi lang sa chemistry na perform ng QC. Dapat sa serology din, dapat sa HEMA din, merong QC. Sa BACTE, sa PASA, no? Sa AUBF, sa urinalysis, dapat merong quality control check. Again, this quality control check will help us to determine whether the results that we obtained are valid and are good to be released. Now, in agglutination testing, the quality control check that we do is through the use of the positive and the negative controls. So these positive and negative controls will ensure the accuracy of our results. Now, during testing class, the control reagents are treated as samples. Tulad ng nakita ninyo sa video, the positive control is placed on the black glass slide, 1 drop. Then the negative control is also placed or dropped on the glass slide, 1 drop. And then the patient sample also 1 drop. So, 'di ba? Pareho sila tigwa 1 drop. And then the reagent is added, the ASO latex reagent is added, 1 drop sa positive control, 1 drop sa negative control, 1 drop din sa patient sample. So the positive and the negative controls are treated just as how the patient sample is treated. Now, the only difference between the control reagents and the patient sample class is that the results or the reactions of the control reagents are expected or known. So, when we say positive control, it is expected to yield a positive reaction. So, dapat doon sa circle kung saan mo nilagay ang positive control reagent, there should be agglutination on that circle. And when we say negative control, it is expected that a negative reaction will be exhibited. Dapat no agglutination will be seen on the circle where you place the negative control reagent. Now, look at this class. Now, look at circle number 1. Circle number 1 here labeled as PC, positive control. Is this a positive reaction? Can you see agglutination? Definitely, there is agglutination. Ito oh, nasa circumference, no? Nasa edge ng circle ang agglutination. So, check. The positive control yielded a positive reaction. Now, look at circle number 3, labeled as NC, negative control. Is agglutination observed? May agglutination ba? Nope, definitely not. The fluid is homogeneous. No clumping is observed. Therefore, negative reaction. Check again. The positive control yielded a positive reaction. The negative control yielded a negative reaction, as expected. Therefore, we can conclude that the testing we did is valid. The reagents are working perfectly fine. The pipetting and the mixing skills of the medtech are okay. Therefore, the results then can be released. So in this sample here, the patient sample labeled as T has agglutination. So positive. Therefore, the patient's result here is valid and therefore can be released. Okay, klaro ba yan siya, class? Now, what if? What if there is no agglutination in the positive control? Or what if there is agglutination in the negative control? There are discrepancies when that happens. Now, anong gagawin natin when discrepancies are encountered? Here is how we troubleshoot in the laboratory. So this here is a flowchart that you can follow if you encounter discrepancies. When you encounter a discrepancy, the first thing that you can do is to recheck the box again. Class ha, remember that before you perform any procedure, check the box of reagent for expiry and signs of contamination before proceeding with the testing. Okay? That will make sure na yung gagamitin niyo na reagent are working well at hindi contaminated. If you experience a discrepancy, check mo ulit yung reagent kasi baka na-miss mo lang or hindi mo na-assess ng maayos. Kung wala ka namang napansin na discrepancy sa box ng reagent na ginamit mo, you repeat the testing using that same box of reagent that you used previously. Okay? Uulitin mo. 'Di ba nung first nag-test ka, and then pag-test mo nakita mo na merong agglutination sa negative control. Pagka gano'n ang mangyari, repeat testing ka using the same box of reagent. And then, during repeat testing, titignan mo ulit yung controls mo. Kung positive control, pasok ba? Nag-agglutinate ba sa positive control? Or kung wala bang agglutination sa negative control. Pag na-resolve yung discrepancy class, okay, expected results are observed, then the result of the repeat testing is deemed valid, therefore you can release the result. But if during repeat testing using the same box of reagent, na-encounter mo ulit yung discrepancy, you have to open a new box of reagent and then check the expiry, check for signs of contamination. And then with the new box of reagent class, repeat the entire testing, repeat the positive control, repeat the negative control, repeat the patient sample using that new box of reagent. And then check for if the discrepancies are resolved. If the discrepancies are resolved, then the result of that testing is valid, therefore you can release the result. And class, ano naman din, in most instances, with a new box of reagent, nare-resolve talaga yung discrepancy. Discrepancies kasi, discrepancies in the control reagents are usually due to contamination or nag-degenerate na yung reagent natin. Once ma-open kasi yung reagents natin, they are prone to contamination and degeneration. May shelf life naman after opening, but nagiging unstable na talaga ang reagent after opening. So kaya when we open a new box of reagent, discrepancies of the reagents and the controls are resolved with that new box of reagent. Okay? So, ayan na-resolve mo na ang discrepancies after opening a new box of reagent. Now, are we going to report the result right away? Are we going to report the positive results, samples? Nope, not really. This may vary between laboratories class ha, but in most instances, in latex agglutination testing, samples that yield positive results are subjected for semi-quantitative testing. Semi-quantitative testing is when we determine the antibody titer. So, when we say obtaining or determining the antibody titer, we are trying to determine the level of the antibodies present in the sample of the patient. Okay? Class, before I forget, tawag sa test, when the test is qualitative, it merely detects the presence of antibody or antigen of interest. So, it is for qualitative testing, it is reported as positive for the presence of antibody or negative for the absence of the antibody. For semi-quantitative, we determine the level, okay? The level of the antibodies or antigen present in the patient sample. So when we say ASO semi-quantitative tests, we determine the level of antistreptolysin O antibodies present in the patient sample. Semi lang siya class because this method is not direct measurement of the antibody, but rather approximation of the antibody concentration by means of computation. Okay? So here is another video of semi-quantitative ASO latex agglutination testing. Okay, so in this video, circles numbers 1, 2, and 3 yielded a positive reaction, whereas circles numbers 4, 5, and 6 negative reaction. So the dilution of the last circle that yielded a positive reaction will be used to compute for the antibody titer. Okay, so in the testing, it is the circle 3. Okay, actually, diba tatlo yun? Circles number 1, 2, and 3 yielded a positive reaction. And it is the circle number 3 that is the last dilution that yielded a positive reaction. So the dilution of the last test cell that yielded a positive reaction will be used to determine the titer. And the dilution of the last test cell is 1 is to 8. So this 1 is to 8 will be used for computation. So how to get the titer? First is to get the reciprocal of the dilution. So again, the dilution is 1 is to 8. So the reciprocal, kabaliktaran of the dilution. So the dilution is 1 to, is to 8. The reciprocal is 8. And then multiply the reciprocal with the sensitivity of the test provided in the package insert. The sensitivity of the tests for ASO is 200 IU per ml. Okay? So, yan ang ginagamit talaga na concentration of the reagent. No? So, you multiply the reciprocal, which is 8, with the sensitivity of the reagent, which is 200. So, 8 times 200. So in ASO, the result may be reported as Todd units or IU per ml. So the titer is 1,000. In this case, the titer is 1,600 Todd units because 8 times 200 or 1,600 IU per ml. Okay? Use Todd units when the streptolysin reagent standard is used, and use IU per ml when the WHO international standard is used. Okay, so how to determine that? Check in the package insert. Okay, for clinicians class, these are the significant titers. In endemic areas, a single positive test is already significant, so no need to repeat the testing. But in non-endemic areas, paired testing, so dalawa ang kailangan in order to have a definitive conclusion. And a two-fold rise in the ASO is already diagnostic for a streptococcal infection. For children, the significant titer is greater than 640 TOD units. The normal range for children is about 240 to 640 units. For adults naman, the significant titer is greater than 200 TOD units. Now, you may be wondering bakit mataas ang reference range sa children. Plus, remember that children are carriers of Streptococcus pyogenes. So, you can expect or you can expect a higher level of antibody titer in this group age than in the adults. So if a child has more than 640 TOD units, that is already significant, no, considered significant. So the doctor can conclude na probably the child has a streptococcal infection. And if for adults naman, the significant titer is greater than 200 TOD units. So going back to the case of our patient, Maria Clara, okay? Again, the doctor here is suspecting of acute glomerulonephritis. So it is necessary to test for ASO, antistreptolysin O, to determine a recent strep infection. Kasi sabi ni Maria, wala naman daw siyang sore throat na naramdaman. Now, Maria Clara sample yielded a positive reaction in ASO testing sa video natin. And then when we perform the semi-quantitative test, yung third na circle sa slide ang nag-yield ng positive reaction. And the third circle has 1 is to 8 dilution. And after computation, we yielded a 1,600 titer of Maria Clara. And 1,600 for an adult is already considered significant. So therefore, the doctor can now conclude that Maria Clara's case is post-streptococcal glomerulonephritis. But the doctor can order additional further tests such as anti-DNAs in order to really confirm that Maria Clara's glomerulonephritis is consequent to streptococcal infection. Okay? Now, ASO testing, di ba sabi ko sa inyo kanina, in the detection of streptococcal antibodies, ASO and anti-DNAs ang common. But between the two, mas common ang ASO testing. Why? Because of these several advantages. ASO remains the best standardized, most reproducible. When you say reproducible, it can be repeated many times. And the testing is the most universal. So gamit siya, it's not just in the Philippines, but also in other parts of the globe. A twofold rise in antibody titer is regarded as definitive proof of an antecedent Streptococcus pyogenes infection. So, the doctor sa case ni Maria, kasi once lang siya na-test, si doctor pwede siyang magpa-repeat ASO testing and then i-compare niya ang titer. 1,600 ang first titer ni Maria. If during the second titer, naging 3,200 or 4,800 ang titer ni Maria. So, nagkaroon ng increase. Therefore, that is already definitive that Maria had a previous Streptococcus pyogenes infection. However, although ASO is a good diagnostic method for streptococcal infection, it also has disadvantages. Now, only 80 to 85% of patients with rheumatic fever have elevated ASO titers. Therefore, false negative results are possible. But about 15%, about 15 to 20% lamang. ASO is not increased in Streptococcus pyogenes skin infections. ASO is significantly increased in respiratory Streptococcus pyogenes infections. Okay, so that ends our discussion for today. I hope you learned something from this discussion. Our reading assignment is posted on the next page in Canvas, and a link to a virtual simulation is also posted. I bet you would want to try that. So thank you for your time and for your attention. Have a good day.